Welcome. Today, the Agency for Healthcare Administration is bringing you a presentation on Florida Medicaid Behavior Analysis Updates for 2019. Today's presenter is Shevaun Harris, who is the Assistant Deputy Secretary for Medicaid Policy and Quality. Before we begin, there are some housekeeping practices we would like to address. The presentation will be available on the agency's website, and you can view that presentation at the following link, http://aka.myflorida.com/Medicaid. From the Medicaid homepage, select Behavior Analysis Services Information. Also, lines will be muted for the duration of the webinar to minimize disruption. Questions can be submitted utilizing the Citrix Questions feature. Simply type your question and select Submit. We do ask that all questions be submitted at the end of the presentation today to assist with managing the volume of questions that we receive. Questions, again, will be held until the end, and we ask that you please wait to submit your questions to help us manage the amount of questions we receive. Okay, I will go ahead and turn the presentation over to Shevaun to present to you today.
Thank you, Sarah. Good morning, everyone. So I'm going to begin today's presentation by providing a brief overview of Florida Medicaid's coverage of behavior analysis services. Florida Medicaid covers behavior analysis services for eligible children ages birth through 20 years of age when medically necessary. As of March 2019, there were approximately 11,000 children receiving BA services statewide. We have 9,400 providers that are enrolled in Florida Medicaid to provide BA services. Of the 9,400, 2,500 are enrolled as lead analysts, 700 are BCABAs, and about 6,000 are registered behavior technicians. We have seen an unprecedented growth in expenditures for this service. We are currently estimated to spend about $500 million on BA services this fiscal year. As with all services, the agency reviews its coverage and payment requirements periodically to determine if changes are needed. Given the growth in service use and expenditures of behavior analysis services, along with the disturbing trends uncovered through our monitoring efforts, we are proposing to implement changes that we believe will allay those concerns. We will also provide program updates on other areas in response to feedback we have received from stakeholders. These changes will help to ensure that services are medically necessary, children are receiving quality care, there's comprehensive care planning, services are being delivered as authorized, and we deter aberrant billing and practice patterns. The topics that will be covered during today's webinar include reimbursement rates, provider enrollment, service authorization, coverage policy changes, and electronic visit verification. Our goal for today's presentation is not only to share information, but to debunk misinformation that has permeated since announcing the proposed changes. We have reviewed numerous comment cards and questions submitted to the agency and recognize that we need to provide more detailed information to address misperceptions about some of the proposed changes, like the multidisciplinary team approach and electronic visit verification. Let's begin with a discussion on the reimbursement rates. When the agency began introducing the proposed changes related to coverage of BA services in late March, we stated that we intended to reduce the rates for some of the BA services. We received concerns about the changes, but more importantly, we received feedback from providers expressing a desire to work with the agency to provide data to help us account for factors that they felt may not have been taken into consideration in both direct and indirect costs. We listened and announced fairly quickly that we would postpone any rate changes and would work with providers over the summer and fall to review any submitted data to inform our decisions moving forward. Some providers still believed that we might proceed with rate changes in the summer or fall. That was never our intent. We heard the concerns and responded. We issued an even stronger statement on April 19th that reinforced that we will not move forward with any rate changes in 2019. For those participating on this webinar who may not know what our reimbursement rates are for VA services, we have depicted them on this slide. These are the current Medicaid rates paid to VA groups. So for the lead analyst, for example, a BCBA, Medicaid currently reimburses the group $76.20 per hour. For the assistant analyst, the hourly Medicaid rate is $60.96 per hour. And for the registered behavior technician, the Medicaid hourly rate is $48.76. We have received requests to never change the rates. Here is our commitment. When we review rates again, we will not start with our own assumptions or data. We will use your salary and cost data as a starting point to help us understand the drivers. This will be done collaboratively through work with the Florida Association of Behavior Analysts. Let's move on to the healthcare clinic licensure requirements. Florida law requires entities providing healthcare services that bill third-party payers like Medicaid to obtain a healthcare clinic license pursuant to Part 10 of Chapter 400 Florida statutes. The healthcare clinic license was created by the Florida legislature in 2003 and is not a new requirement. The Healthcare Clinic Act was enacted to strengthen the regulation of healthcare clinics to prevent significant costs and harm to patients. The law requires licensees to meet a minimum set of standards that provides added safeguards. The law also allows for certain types of providers to be exempted from the license. All providers seeking enrollment in the Medicaid program must comply with the healthcare clinic licensure requirements if applicable. Therefore, the agency will be requiring VA groups to furnish proof of the healthcare clinic license or provide a copy of the certificate of exemption by July 1, 2020. You may be wondering why the agency is asking for this agency now. Providers should have always self-reported their license number to the agency when they submitted the provider enrollment application. The agency has become aware that some of our providers who seemingly are required to obtain the license have not and are engaging in unlicensed activity. This is against the law. This initiative will allow the agency to validate that all providers who are required to possess a healthcare clinic license have one on file or have submitted a certificate of exemption. This initiative is not limited to VA groups. We will be confirming that all providers for which this licensure type applies has provided it to Florida Medicaid. The agency is committed to working with providers to address any questions that they may have on the healthcare clinic licensure requirements and to provide additional technical assistance. The agency has additional information on its website regarding the licensure requirements. On this slide, we have hyperlinked the word website. Once it's posted, you can click on that hyperlink and it will take you to the agency's page. On that page, you will find links to applicable statutes and rules, forms for licensure and exemption from licensure, survey regulation sets, and frequently asked questions. If you need assistance, please do not hesitate to contact the agency at the numbers or email address on this slide. Next, we will review a new model for reviewing service requests for children with maladaptive behaviors who are seeking behavior analysis services through a multidisciplinary team approach. The agency will be implementing a multidisciplinary team model for authorizing behavior analysis services. The model will also include a care coordination component to assist with care planning. The MDT approach will be implemented in Regions 4 and 7. Counties in Regions 4 and 7 include Baker, Clay, Duval, Flagler, Nassau, St. John's, Volusia, Brevard, Orange, Osceola, and Seminole. The model will be implemented July 1 in these counties. The MDT approach helps to ensure that children with special health care needs are receiving the most appropriate and comprehensive service package to meet their developmental and behavioral needs. Based upon a review of the literature, interprofessional collaboration using a multidisciplinary approach can be a major determinant in increasing healthcare and educational outcomes of children with special healthcare needs, including children with autism spectrum disorder. As the majority of requests for BA services are for children with a diagnosis of autism spectrum disorder, the model helps to review whether the child is receiving care across all of the disciplines needed to effectively treat the presenting symptoms, such as psychology, occupational therapy, physical therapy, nursing, and nutrition as examples. The model will not undermine the value of BA in addressing the child's behavioral challenges. In fact, the model will support it. According to the DSM-5, about 70% of children with ASD have one comorbid mental disorder, and 40% have two or more comorbid mental disorders. With such a high prevalence of comorbidity among individuals with ASD, a multidisciplinary team approach can be useful. It further provides the clinical reviewers with additional consultative support from other licensed practitioners in the review process. The MDT model is not intended or designed to reduce BA or ABA services for children. Again, the model is actually intended to support it and ensure that there are not unnecessary denials and that the reviewers have the most relevant information needed to make a good clinical decision. The MDT model deploys a child-centered approach. The team revolves around the child, and the primary and most important goal is to ensure that children receive all medically necessary services, including those that may not have been identified yet, but may be beneficial to the overall success of the treatment goals. The MDT model will be managed by our current prior authorization vendor, EQ Health. Members of the team include the parent, a service coordinator assigned by EQ Health, clinicians from EQ Health, a physician, the child's health plan, and providers involved in the child's care. A BCBA will always be one of the clinicians that participates in the MDT review process. The other clinicians may be a speech therapist, occupational therapist, or behavioral health counselor. You may notice that one of the participants is the child's health plan. Did you know that 90% of the children receiving VA services are enrolled in health plans? This means that Medicaid health plans are providing and coordinating the vast majority of all other medical and behavioral health care that that child needs. The health plan and other providers involved in the child's care do not have to participate, but the option will always be there. We will ensure that if referrals or recommendations come out of the MDT approach, that the service coordinator will follow up with the health plan and any other providers who do not participate in the process to ensure that they stay informed. The model affords the agency the greatest opportunity to collect information from multiple sources about the care needs of the child, including direct contact with the parent and child. The agency has extensive experience with using this approach for children with special and focused healthcare needs. It has been used for children who require private duty nursing services, prescribed pediatric extended care services, personal care services, and statewide inpatient psychiatric care. EQ Health is the vendor currently managing the MDT model for many of these services. So let's move on to how the MDT approach will work. The first step in the process is for the provider to contact EQ Health via phone to request authorization. This should be done at least 30 days before services are initiated. An intake coordinator will collect information from the provider and request documents be faxed, such as the behavior intervention plan, data books, and any assessments or reassessments. EQ Health will enter the information in EQ Suites on behalf of the provider, reducing administrative burdens and the potential for administrative pens. Each child will be assigned a service coordinator. This person will contact the parent to collect additional information. The service coordinator will also help to serve as a resource for the parent in understanding the process, and if additional services are identified as needed, the service coordinator will help the parent get those services established. As an example, the service coordinator might help the parent get additional supports from the Early Steps program. The discussion with the parent should be completed within 2 business days of the request. If the request for services is for 20 hours or more, a team meeting will be scheduled with the parent during the first call to save time. The next step is for the BCBA to review all of the documents that EQ Health has received. This review will be complete in 5 days. The other clinical reviewers assigned to the request will also review the information. Let me be clear, they are not reviewing to determine if VA services should be approved or denied. Only a BCBA, BCBAD, or physician will have that authority under this model. The other clinicians will offer their clinical expertise based on the presenting symptoms of the child to help achieve the highest quality of care and degree of functioning. If the BCBA needs additional clinical information, he or she will have the opportunity to call the provider. Again, this process reduces administrative burden on the provider in having to respond to requests in EQ Suites. When needed, the MDT meets to review the case. The meetings will most often occur telephonically. A decision will be made in real time at the meeting. The service coordinator will assist with any referrals needed, as stated before. To help facilitate the recertification process when requests are approved, EQ Health will automatically approve a reassessment to be conducted in 6 months, so the provider does not have to request that reassessment via EQ Suites or over the phone. The entire process will be complete before services are supposed to start. EQ Health will also have an expedited process for urgent requests. EQ Health will issue administrative authorizations that provide a little bit more time to complete the review process if delays occurs that were of no fault of the recipient or the provider. As you can see from this chart, the intensity of the model increases as the number of requested hours increase. The higher the intensity of services, for example, 24 quarter hours or more per day, the increased frequency of monitoring, including the submission of updated data to demonstrate progress. Requests for less than 20 hours per week does not require a team meeting. Requests above 20 hours per week require a team meeting. Requests for more than 30 hours per week will be reviewed at a minimum on a quarterly basis. EQ Health Solutions will begin these team meetings in July of 2019 in the pilot areas in anticipation of recertification reviews for children who are currently receiving VA services. EQ Health may begin to contact parents in late May 2019 to help expedite the process. Parents will be notified by EQ Health, again, when their child's team meeting is scheduled. If they need to make changes, EQ Health will work with the parent on scheduling changes. Based on the enhanced oversight that the MDT model affords, the agency is exploring implementing a reward program in those regions that recognize providers that exceed certain quality benchmarks by reducing the frequency of having to request recertification on certain cases. This means longer authorization spans. Some ideas that we are exploring include reviewing whether or not the provider is stating services appropriately and in accordance with the behavior plan, whether the provider is submitting comprehensive data books each time, and whether the provider has low requests for additional information. We want your help in designing this program. We will need time to evaluate the quality performance of the providers, and so we are thinking we will not implement this program until spring of 2020. But if you have any feedback on the design of this program, please let us know. The MDT approach has a number of strengths. The parent and child will have greater opportunities to be involved in the process. The process reduces administrative burdens on the provider. It enhances quality oversight in the delivery of services, as EQ Health will have more direct contact with the provider and have the ability to address any concerns in real time. It improves communication between all parties involved in the review process, the parent, the provider, and the reviewers. And the model facilitates more interactive communication and moves away from a paper-based process. The model identifies or will identify service needs and gaps so that they can be resolved quicker. It will offer parents additional resources and support through the help of a service coordinator. This has really worked well for other services covered for children with special health care needs, and is being replicated here as a best practice. The process will also improve the authorization turnaround time, as reviews will be pended less frequently and questions will be resolved faster. Additional training about the model will be offered by EQ Health and will begin the week of May 6th. Next, we will move on to proposed changes in the Behavior Analysis Services Coverage Policy. The agency is in the process of revising its Medicaid Behavior Analysis Services Coverage Policy. One proposed change is to merge the policy with other policies that Medicaid or other services that Medicaid covers related to behavior modification and intervention services, such as behavioral health day services and therapeutic behavioral on-site services, or TBOS. This will highlight the continuum of services that are available for children with maladaptive behaviors. We will update the policy to strengthen the requirements, holding true to the principles and rigor of applied behavior analysis supported by evidence-based practices, including demonstrating evidence that parent training is occurring to ensure that parents are developing the skills needed to execute the procedures on the behavior plan. Additionally, this policy will expand upon provider supervision requirements and clarify documentation requirements. These changes will reflect the industry's best practices. The agency will be hosting rule workshops and hearings for the public to be involved in the rulemaking process. If you cannot attend in person, you can submit comments in writing. These policy changes will be effective when promulgated into rule, tentatively scheduled for this summer. To stay informed about rule workshops and hearings, you can review notices posted in the Florida Administrative Register or sign up for our provider alerts. The agency will clarify the requirements related to billing of supervision. We will clarify that the lead analyst may seek reimbursement from Florida Medicaid for up to 8 hours of supervision of the RBT or BCABA per month. There has been confusion about whether supervision is billable, and we want to clarify that the lead analyst may bill for that time. These billable hours are not on top of or in addition to the hours already approved for the child. It must be an in-person individual visit, and the child must be present. The lead analyst must be directing the RBT or BCBA during the visit, and the RBT or BCABA may not concurrently bill during the same time. Again, both entities or providers may not concurrently bill during the same time. Only the lead analyst may receive Medicaid reimbursement. The supervision activities must include observation of behavioral skills training and delivery of performance feedback, modeling technical and professional and ethical behavior, and guiding the development of problem-solving and ethical decision-making, including going over target interventions on the behavior plan and modeling how those should be implemented. If the lead analyst is not a BCBA, but is licensed in another behavioral health profession, for example, a licensed mental health counselor, the lead analyst may only bill for the supervision of an RBT if operating under the oversight of an RBT requirements coordinator. This is consistent with the requirements of the board. The RBT supervisor form found on the board's website must be maintained in the employee record under these circumstances and be available upon request by the agency. Providers will have to submit a comprehensive diagnostic evaluation when requesting the initial service authorization on new cases. This is considered the standard of care to determine the diagnosis and service needs of the child. Providers will also have to submit updated evaluations every 2 to 3 years when requesting continued authorization. Again, this is a standard of care to identify changing needs. Updated evaluations may target specific skill deficits and are not required to be comprehensive. If a child is currently receiving BA services and has not had an updated evaluation within the last 2 to 3 years, EQ Health will give you time so parents can work with the child's physician to have the evaluation completed. For children in the regions 4 and 7 receiving BA services, The service coordinator can help parents with these tasks as a part of the MDT model. The behavior assessment or functional assessment will also be strengthened in terms of requirements in the coverage policy. We will clarify that the behavior assessment or functional assessment must consist of the following: an objective list of direct observations, tests to define target behaviors, interview records, operational definitions of all behaviors targeted for change, a description of conditions under which the behavior is most likely to occur, measures of the current level of behavior targeted for change, and putative functional relationships between the targeted behavior and the environment. We will also update requirements related to the behavior intervention plan. The behavior intervention plan must consist of the following: a summary of program monitoring and any other factors affecting behavior, graphic and narrative summary of all target behaviors, analysis of data and a summary of progress, a plan for maintaining and generalizing behavioral improvements, and criteria for the reduction and fading of services. As caregivers show increasing competence in delivering the implementation plan and the recipient's target behaviors are responding to effective treatment, the plan should set forth target behavior criteria to be achieved by the recipient that leads to a specified reduction in the level of service. Subsequent to the development of the initial plan, an updated fading plan should be addressed. We will also strengthen the requirements related to the submission of the data book. The data book must include the following: dates when each specific observation occurred, the number of responses emitted during an observation period, the rate, frequency, and duration of target behaviors, the measure of change across a period of time, and graphs that chart the measurement and pattern of target behaviors. Lastly, additional documentation requirements will include appointment logs signed and dated by the child's parent or guardian, treatment and/or progress notes signed by the provider, and documentation of training for parents and caregivers to ensure program effectiveness. We will move on to a discussion on implementation of electronic visit verification. The agency will be implementing an electronic visit verification system that will ensure that services are delivered timely with the appropriately credentialed staff and in accordance with the authorized units of service. The agency will implement electronic visit verification, or EVV, for BA services effective September 1, 2019 in regions 9, 10, and 11. Counties in regions 9, 10, and 11 include Indian River, Martin, Okeechobee, Palm Beach, St. Lucie, Broward, Miami-Dade, and Monroe. The agency may add regions at a later date. The implementation of an EVV system allows the agency to be assured that visits are occurring timely by the right provider and in the right location. The process will also ensure a heightened degree of provider accountability, not only to the agency, but also to the children served. EVV has been in place for Medicaid-funded home health services for many years and has proved to be an effective deterrent to fraudulent and abusive billing practices. This initiative will not interfere with the delivery of care to recipients. Children will continue to receive VA services as authorized. The agency is confident that through this system, we will be able to identify whether services are not delivered or if services are not delivered appropriately, and we will have the ability to intervene to assist, including finding a provider that will fully meet the recipient's needs. Training will be available to providers both in person and through live web-based sessions. We will review training opportunities in a few slides. Providers will need to register with the vendor to use the EVV system. The vendor that the agency has selected is TELUS. Group providers will help their rendering providers get set up in the EVV system. The group will serve as an administrator. Once EVV is implemented, providers will bill through the EVV portal and no longer bill via the Florida Medicaid Management Information System. Providers will have full quality assurance control over claims that are submitted through the EVV portal and will be able to reconcile and fix any discrepancies on the claim before it's submitted. Providers will still need to receive prior authorization through EQ Health before delivering services. Once authorization is obtained, providers will use the EVV system to schedule services based on the prior authorization. Providers will have the ability to make updates to scheduled services. The system will offer the administrator flexibility to make modifications based on unforeseen circumstances. If services were not appropriately verified at the time of delivering the service, the administrator will be able to reconcile these occurrences in the system so claims can get paid. EVV requires the registered behavior technician, lead analyst, and board-certified assistant behavior analyst to check in and check out using a smartphone application enabled with GPS technology each time a visit begins and ends. The system will only be required for use with services that are rendered by the RBT, lead analyst, and BC ABA. It will not be required for the assessment or the reassessments. A number of checks and balances are in place to ensure that the information submitted on the claim is valid and aligns with information from the prior authorization system and other sources of information. The provider will not be able to receive Medicaid reimbursement for services that have not been verified through the EVV system. The technology will work regardless of location, so it will work in those instances where services are delivered outside of the home. For example, a daycare setting, the park, the grocery store, etc. The vendor will have an app that can be installed on computers for check-in and check-out purposes for providers that offer clinic-based services and have expressed concerns about having smartphones in that setting. Webinar trainings will begin May 15, 2019 and run through September 2019 on the EVV system. Training will be offered weekly and is separated by topic: scheduling and use of the dashboard, claims, and use of the mobile application. Approximately 100 individual training sessions will be offered. Training sessions will be offered multiple days of the week on a flexible schedule throughout the day and early evening. Spanish sessions will also be offered for each training topic. Once the program is implemented, refresher training courses will also be available and offered. In-person training will start June 12, 2019 and run through August 2019. In-person training will focus on scheduling and use of the dashboard and claim submission. Multiple in-person training sessions will be offered in one location per region. Approximately 25 individual in-person training sessions will be offered. Let's move on to an update on the provider enrollment moratorium. The agency has had a moratorium in place in Miami-Dade and Broward counties since May 2018 in response to the rampant fraud and abuse activities occurring in those two areas related to BA services. The agency has implemented a number of safeguards over the last year and feel that as we initiate additional programs such as EVV in the near future in these counties, we are at a place where we can request federal permission to partially lift the BA provider enrollment moratorium in those counties. We are specifically seeking permission to lift the moratorium for registered behavior technicians, lead analysts, and board-certified assistant behavior analysts seeking enrollment to participate as a member of a group that is already enrolled in Florida Medicaid. The moratorium will remain in effect for new group providers and lead analysts practicing independently. By partially lifting the moratorium in this manner, it allows provider groups that are already enrolled in Florida Medicaid to fill vacancies and meet any increased demand for services. We must again receive permission from the Centers for Medicare and Medicaid Services before we move forward. We have been in discussions with them and anticipate that we will be able to proceed by mid-May. We also need to modify our system to accept new applications in these counties. We will let you know when we are ready to begin receiving these applications by issuing a provider alert. Please do not begin submitting applications in these two counties until we let you know. The agency continues to streamline the provider enrollment process and educate providers on ways to facilitate the application approval process. We heard your request for additional guidance around the enrollment process and scheduled webinars on April 23rd and 24th. If you are not able to attend one of the webinars, a recording of the webinar will be posted on the agency BA webpage soon. Additional live webinars will be scheduled in the near future if there's ongoing interest. It would be helpful if you let us know if there are any other questions or training needs that were not addressed by those webinars that have already been held. The agency will continue to hold webinars in April and May. Well, actually, today's the last webinar for April. We will have one more webinar on May 10th. In addition to these meetings, there will be publicly noticed rule workshops and hearings regarding the policy updates. We will continue to keep our providers informed through website updates and through provider alerts. For your convenience, again, the agency website is on this slide. If you go to this link and click on Behavior Analysis Services information, you will be able to stay updated and informed on any changes. To sign up for provider alerts, follow the instructions on this slide. Again, visit the agency's website and you will click on Sign Up for Program Updates. The agency has also established a dedicated email address for comments and questions specifically related to behavior analysis services. That email address is bacomments@aca.myflorida.com. You may also contact the Medicaid helpline toll-free at 1-877-254-1055. This concludes the presentation portion of today's webinar. Again, thank you for your time. I hope you have a great rest of the day.